Hello, welcome to Johns Hopkins Medicine online webinar series. Today, Johns Hopkins gastroenterologist Margaret Jerry Keene will speak about endobariatric weight loss options. Before we get started, we'd like to provide some user tips so that you're comfortable using this platform. The first 30 minutes of our program will include an informative presentation by Dr. Keene. The last 30 minutes will be dedicated to our live Q&A session. To submit a question, please type your question into the Q&A box and click Send. Your questions will be seen by others watching this presentation, so please note, if you do not want your name attached to your questions, please check Send anonymously. We will do our best to answer all the questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. Please note, this program is being recorded. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of the talk for you to complete the survey. And now, I'd like to welcome Dr. Keene to begin her presentation.
Good afternoon, everyone. I'm delighted to be here. So I'm Jerry Keene. I'm one of the advanced and bariatric endoscopists here at the Johns Hopkins Hospital in Baltimore. And I also work at Sibley Memorial Hospital in DC. And I'm really pleased to be able to talk to you about some endobariatric weight loss options that we have available. And I'm going to start by talking about some definitions that we use around endobariatrics and obesity, just so that when you come to your first clinic appointments, you can really understand everything we're talking about in lots of detail. I want to talk to you about why we do this. What's the consequences of being overweight, and what are the benefits of maintaining a good, healthy weight long term? What endobariatric weight loss treatments do we offer? I'm going to go through them in detail. And I'm also going to talk to you a little bit about what our multidisciplinary approach to weight management involves, all the people that we have involved in your care, and also why we think this is really key to great management and long-term success. And as Kristen said, we will at the end have lots of time for your questions. So let's start with a definition of obesity. Well, the Obesity and Medicine Association have quite a complex definition, but this is an abbreviated version. And what they describe it as is a chronic, relapsing, multifactorial disease that results in increased body fat and adverse health conditions. And many of us will recognize parts of this as very much close to home. It's certainly a chronic disease. You often lose some weight, you often regain that weight, maybe lose it again. Relapsing as part of the course is very familiar to many. We also recognize that there's multiple reasons why you might gain weight, and we think understanding those very carefully is also a key to success and something we focus on when we see you. The other thing to remember is you're not alone. So in the US, obesity has increased significantly over the last 3 decades. In fact, it's tripled in frequency. Currently, almost 40% of US adults are obese, and this is increasing year on year. And why is it important? Well, it's important because of the impact it has on your health. It can cause a number of medical problems. It can lead to strokes, cataracts, different cardiovascular diseases, including diabetes, high cholesterol, blood pressure. It can also make certain medical conditions worse, like pancreatitis. It can be a risk factor for certain cancers. It can lead to osteoarthritis and needing joint replacements. It can lead to infertility, gallbladder disease, fatty liver disease, and in a proportion, even cirrhosis. It can cause lung problems like sleep apnea and hyperventilation syndrome. What are the consequences for society more widely? Well, obesity is responsible for 300 deaths annually, and it's becoming a leading cause of preventable death. It also costs a lot of money. It's responsible for nearly 200 billion of medical costs every year. For the individual, there's also an impact. It decreases someone's productivity, it results in lost wages, and of course, we all know it has psychological impacts leading to discrimination and stigma. So what treatments are out there? Well, you should really think of the treatments for obesity like a ladder. Right at the bottom rung is diet and lifestyle changes. We all know about these, and of course, they come with very little side effects. But long term, we know they're very hard to maintain. So what about the next rung of the ladder? Well, there are many anti-obesity medicines that are now available and approved by the FDA. We read about these frequently in the press, and their efficacy is also improving all the time, which is really exciting. However, they do come with side effects in a proportion. There's also questions about what we do with these medicines long term. And of course, there has been problems with more and more people taking them with availability. And we know that only a small proportion of all the patients that should be having them actually get them. So what's at the top rung of the treatment ladder? Well, of course, bariatric surgery is the gold standard treatment for obesity. It's highly effective. We know this, but it is invasive. It also comes with some risks. It's also not reversible. The process of getting through the workup to have bariatric surgery can also be challenging. And of all the people that are eligible, we know that only 1 to 2% of all those people actually undergo bariatric surgery. So is there an option in the middle? And this is where endobariatrics really comes in. And why is it attractive and such a great treatment for all those people we're currently not treating with obesity? Well, it's minimally invasive, particularly compared to surgery. It's by and large an outpatient procedure. You go home the same day. It's reversible. If you change your mind or things change in the future, it's also repeatable. And in most cases, it doesn't prevent you having, if you choose to undergo bariatric surgery in the future. There has been some limitations that have been put at the door of endobariatric treatments. One of them's been cost. One of them is how durable is this treatment? How long will my procedure last? And I'm going to answer those questions. So let's take you to your first office visit to talk about endobariatric procedures. Well, we offer visits either virtually or in person at our Sibley DC site. And you'll see either myself or my nurse practitioner, who's Kristen Collar, who's very experienced and has been working in the endobariatric field now for more than 6 years. We start by taking your weight and your height and calculating your body mass index. This strategizes what treatments that would be suitable for you. I then always like to talk about what prior weight loss strategies you've tried, what's worked, what hasn't worked, what's been the difficulties with each. I'll go through your health history in some detail. And really in that, I want to see if there's any factors that could be driving weight gain. I also want to see if there's anything that's going to be a problem for when we plan procedures, specifically for anesthesia, and if you might need an anesthetic assessment. And if there is, that's not a problem. We can schedule that. I'll look carefully also at your medicines. Again, I'm looking if there's anything that could be driving weight gain that we can stop. I'm also looking to see if you're on any anticoagulants or blood thinners that we might have to have a plan for during the procedure. I also want to look very carefully at any factors that might be a barrier to your success and to see if we can work together to address those so that you have the best opportunity to get a great outcome. So first of all, what is BMI? Well, body mass index is this complicated equation at the top of the screen, and you're not expected to remember this or understand it. There's many very simple BMI calculators that are out there that we put in your weight and your height that give us a number that then classifies you as either being underweight, of a normal weight, overweight, or obese. And if you're obese, then you will qualify for one of these procedures. There are some provisos for this. Like everything, BMI is not perfect. There are certain races and ethnicities where it just doesn't apply as well. At extremes of age, it also doesn't work so well. And also in patients with a high muscle mass, particularly athletes, they often are deemed to have a high BMI, but in reality, they're not obese. So how do we select patients? Well, generally we select patients for endobariatric treatments if they have a BMI above 30, but that's not the whole story. We do select some people with a lower BMI if you have some comorbidities like we discussed, heart problems, diabetes, where you may benefit from weight loss. So which procedure are you eligible for? Well, we start by asking you if you've had bariatric surgery before or not. And if you haven't, the primary procedures we offer you are an intragastric balloon or an endoscopic sleeve gastroplasty. And I will talk you through why you might select one or the other. If you've had surgery before for weight loss, I ask you a little bit more about what type of surgery you've had. And if it's a gastric bypass, you may be eligible for something called the transoral outlet reduction procedure, or the TOR procedure for short. If you've had a gastric sleeve previously, or indeed an ESG and regained weight, I will talk to you about a revision endoscopic sleeve gastroplasty. So let's talk about the intragastric balloon first of all. And sometimes it's helpful to think about this in the context of a patient. So this was one of my patients. She was a 68-year-old woman with a BMI of 39. She tried multiple diets and weight loss programs in the past without success. Her main problem currently was that she had severe osteoarthritis. She was awaiting a knee replacement. But before her orthopedic surgeon would schedule her surgery, he wanted her to lose about 40 pounds so he could undertake the surgery safely. So she came to me for an intragastric balloon. Now, an intragastric balloon is FDA approved for a BMI between 30 and 40. We sometimes do it outside of this BMI in particular clinical indications, so we can always discuss that with you. There are some contraindications to an intragastric balloon. If you've had prior surgery on your stomach, we can't place a balloon. Not while you're pregnant, and then there are a number of other things that we look for: inflammation, ulcers, hiatal hernias, that typically we do when we come to do your endoscopy to check you don't have any of these. And this is a video of what the procedure involves. So we start with a simple endoscopy. You're very comfortable and completely asleep during this process. We pass the endoscope down into the stomach. We look carefully in the esophagus, make sure there's no food retained, no motility issues. We look in the stomach, check there's no inflammation, no ulcers, nothing like that. We then place the gastric balloon down into the stomach. This is all done under endoscopic vision. Then we start to inflate the balloon, and we do this by removing the stylet that's been used to guide the balloon down into the stomach. We attach a syringe and eject saline, which is a salty water solution, to inflate the balloon to between 500 and 700 mils. Once fully inflated, we simply pull the catheter back and release the balloon into your stomach, and it sits in your stomach, and it's about the size of a grapefruit. Now, the intragastric balloon works in two ways. It fills up a lot of the space in your stomach so you feel more full, It also delays gastric emptying by preventing the stomach from emptying fully. So in two ways, it can really help you feel more full and assist with weight loss. The balloon stays in place for about 6 months. Then, at the end of that, we perform another simple endoscopy, puncture the balloon, insert a catheter into the balloon, and remove all the fluid that we've inserted, shrinking the balloon down. Then we simply grasp the balloon and remove it again via endoscopy. And how did my patient do? Well, she went home the same day. She did have some nausea for a couple of days after the procedure. This is not unusual, and actually it's a good sign that you might have good weight loss. We have excellent medicines that help you control that, and she did very well. And indeed, when I saw her at 5 months, she'd lost 35 pounds. This is 13% of her total body weight. Her knee replacement was scheduled, and we were planning to remove her balloon in a few weeks. So one limitation of the gastric balloon is that we always worry about what happens once the balloon is removed. Could the weight come back on? And yes, it can. Now look, it depends on each case. In this scenario, I know she's going to get back to a much more active life, playing with her grandkids. I don't think that's going to be such a problem. But if it does happen, we can employ combination therapy with medicines. And this is something that's very useful to halt weight gain and something that our multidisciplinary team can talk to you about. Now, what happens if your BMI is a little bit higher, or maybe you want a more durable procedure? Well, maybe the next step to think about is something called the endoscopic sleeve gastroplasty. Now, there are a number of suturing devices that are available to go on the end of the endoscope that are FDA approved in the US. One of them is the Overstitch, the Pose, and the Endomina devices. And we have 2 of these available at Hopkins. The Overstitch device has been around the longest, and recently it's received FDA de novo authorization specifically for endobariatric procedures, which is a fantastic development forward. So it's been approved to perform the ESG procedure and also the revision procedure, the tool. There's also the newer device, the Endomina device, which has just come to be available in the US. And this is, early studies from Europe show that it's equally efficacious. And our hunch is that maybe some of these sutures might last longer, but we have to wait and see. And we also have this device available at Hopkins. And this is how it works. So this is the device. You can see one end of it, I load on the end of the endoscope. This is where the needle sits. And then I control that needle with this handle, which sits on the shaft of the endoscope. Then I'm handed the suture. This is what I use to place the sutures in the stomach. And this is us loading it. It goes down the working channel of the endoscope. We load it on the end of the endoscope, pass this down into your mouth to be able to do the sutures. So let me take you through another patient who had this procedure. This was a 39-year-old female. She had a BMI of 43. She had type 2 diabetes and fatty liver disease. And there was some concern because her fatty liver disease was progressing. She now had moderate fibrosis. She tried multiple diets and weight loss programs in the past without success. She'd also tried some of the medicines for weight loss. She tried phentermine, but it gave her poor sleep, palpitations, and she had to stop this medication. So she was referred to me for an ESG. This is our video that describes the ESG procedure, and you can watch it again on our website. So this is how we do the procedure. We place the device that you've just seen me load down into the patient's stomach. I check, first of all, just like with the balloon, that there are no contraindications to the procedure, no significant inflammation, large hiatal hernias. Then we mark the anterior and posterior walls of the stomach, and this guides us to where we're going to place the sutures. We then draw up the stomach wall at various points, moving from the anterior to the posterior walls of the stomach in lines, placing the sutures through the stomach wall in the series. And then what we aim to do is bring all those sutures tightly together. And we do this line after line with the aim of reducing the stomach down to a quarter of its size. So it's significantly smaller than it was before. Now, after an ESG, this patient was discharged home the same day. She followed a liquid diet. She did have some nausea and a small amount of pain. Now, again, we have excellent medicines to control this. She was a nursery nurse and has quite an active job. So she took about a week off work after this procedure, which is about what we recommend. She had no adverse events, which was great. And when I saw her back in clinic, she'd lost 30 pounds. She had 11% total body weight loss, and she was right on track for where we want her to be at that point. Importantly, her A1C had normalized and her liver function tests had been in the normal range for the first time in 2 years. She was ecstatic and her hepatologists were delighted. Now, of course, this is just one patient. What about everyone else? Well, there was a clinical trial that was published in 2022 in The Lancet. You know, ESG has been around for a number of years. It's been around for about 11 years now. But this trial really was the first time that we got randomized data to assess it fully. And it compared the ESG to intensive diet and lifestyle changes. And what they found was that with an ESG, weight loss at 1 year was 13.6%. But actually in the diet and lifestyle group, it was less than 1%, showing that it was a really significant difference between the two groups. And this really paved the way for the FDA de novo authorization that this procedure has now received. Now, this can be quite confusing to understand, but what it means for patients is we're getting more reimbursement and we're getting better Medicare coverage. So these are great steps forward for this procedure. Adverse events were also very low, less than 2%. So what about that question of durability that we brought up right at the start? How long will my ESG last me? Well, you know, nothing lasts forever, even with bariatric surgery. Remember, obesity is a relapsing condition. But, you know, this study that came out of New York really showed that actually ESG has some real durability. Their patients had lost 20% of their total body weight at a year, and actually at 5 years had maintained 15%. Adverse events, just like in the MERIT trial, were very low. One thing to note, though, is that a good proportion of their patients needed combination therapy. So around about a third needed medications, 6% needed a revision, ESG, only 1% went to surgery. And this is the main reason why we think a multidisciplinary approach is key to keep you on track. And also if you need further treatment down the line, we're there to offer it. Now, what about cost? Well, historically, an ESG has been a self-funded cash pay procedure, but things are changing. You know, with excellent publications like the MERIT trial, you know, we're now seeing more insurance approval. That FDA de novo authorization really changed the landscape for these procedures. We've also received Medicare coverage. So if you have Medicare, you can now have this procedure. And we have the devices that are available at Hopkins to be able to do that. Of course, insurance approval is not guaranteed. But our office is very experienced and we're very happy to talk you through that process and give this a go. So what about revision endobariatric therapies? So this is another one of my patients. He's a 50-year-old male. He had a gastric bypass in 2005. He lost around about 130 pounds. But like many, during the pandemic, regained 80 pounds and had redeveloped dumping syndrome. His diabetic control had got worse and he was referred to me for a transoral outlet reduction endoscopic procedure, or something called a TOR procedure. And this is what the bypass looks like after the surgeons have finished. But what can happen over time is the gastric pouch and the gastric outlet can both stretch. And this is what we aim to treat endoscopically. So the first thing we do is we heat treat the edge of the gastric outlet with something called APC. This, removes some of the mucosa, but as it then heals, it causes a scar and means that it fibroses and comes together to narrow that outlet. We reinforce that scar with suturing. So we suture in a purse string fashion all around the edge of the outlet. And when we tighten that suture, this also reduces down the outlet. And we bring it down to sort of 6 to 8 millimeters, back to how it was after you had your surgery. In the second part of the procedure, we also work on the gastric pouch if it's dilated. And to do this, we place sutures similar to what we do during the ESG along the gastric pouch. And again, we tighten those together to reduce it in size. So how did this patient do? Well, he did brilliantly. So at 6 weeks, he'd reported 18% total body weight loss. He really was one of our success stories. It's not for everyone, the average weight loss is more like 10%, 9 to 10%. But I always say to patients, this is the procedure with the biggest arms. Some people can lose an awful lot more, and he was one of them. His diabetic control had improved significantly. That's no surprise. He'd returned to exercising, and I've just seen him in clinic 1 year later, and he's now lost 40% of his total body weight, and he's doing really, really well. So what happens if you've had a laparoscopic sleeve before, or indeed an ESG, and regained weight? Well, we can consider a revision ESG. Now, one of the reasons you might regain weight in this scenario is because your sleeve is dilated. So the first thing we want to do is assess that endoscopically and with X-ray. And if you've had sleeve dilatation, this can be treated with a revision endoscopic sleeve gastroplasty. And this is done very similar to the way a standard ESG is done. It's just a smaller area. Now, what's on the horizon? Well, the great thing about being in endobariatrics is there's always new devices and exciting therapies coming online. And at Hopkins, we want to be at the forefront of that every time. So, one exciting therapy that's out there is duodenal mucosal resurfacing, which is a novel procedure that treats the duodenal mucosa with either heat or with electrical pulses that allows you to improve your diabetic control. In some patients, it may even reverse your need for some of your insulin. And in a certain group of patients, it may also lead to weight loss. So we're hoping to incorporate this therapy into our portfolio as part of a clinical trial later in the year. So next, I just want to really talk you through our approach to weight loss and our multidisciplinary components of that. So endobariatrics at Hopkins has been around for a long time. The ESG had its 11th year birthday, and Hopkins was one of the first centers to offer these endobariatric treatments. Research and education is at the forefront of what we do, and we're always involved in pioneering new techniques. We have a very experienced team, and I'm going to introduce you to some of them today. And we do endobariatric procedures every week. So this is the team. So Kristen Collar, you've already met, and you may also meet her if you come to one of our clinics. Lauren Bollard is my nurse, and Kiana's my secretary, who will do a lot of your scheduling for clinic appointments, endoscopies, and also helps with some of the financials and sending you out any additional information you need. She's very experienced and will answer a lot of your questions. Now, what about all this reimbursement you've heard about? Who's going to handle everything with my insurance company? Well, Yolanda Wilkie is our authorization specialist, Andre D'Souza is our practice manager, and they're very experienced in helping you through that process. It can be lengthy, it can sometimes take a few months, but we've had many success stories and we're very happy to try. Now, on the clinical side, there's one thing about doing the procedure, but we believe that follow-up is key to success. And we've embedded our program in a partnership with the Johns Hopkins Healthful Eating, Activity and Weight Program. This is quite a long title, and you can simply call it the HEAP Clinic. Now, within this clinic, there is a number of providers that you can meet, that you can see on the right, and they are internal medicine specialists and obesity medicine specialists, all board certified in both. And what they offer is all the access to the latest FDA-approved medicines for weight loss. They have all the access to all the specialties that can manage any comorbidities you might have that are related to your weight. You know, they're excellent partners to give us really comprehensive care. And this is what we expect that your first year will look like. So before the procedure, you'll be carefully assessed by myself or by Kristen. If you're going ahead with the procedure, we'd also ask that you will see the HEAP, the medical obesity specialist in the HEAP team. We'd also ideally like you to see the dietitian. We then schedule the procedure, do that, and then we will see you very carefully, up to probably 10 visits during that first year after the appointment, after your procedure. And the idea is that with all these touch points, we really want to keep you on track. And we think that seeing different people, seeing the medical obesity specialist, seeing myself, and also seeing the dietitians allows you to have fully comprehensive and different aspects of care to really achieve your goals. So we keep diet post-procedure as simple as we can. We keep it the same for all of the procedures we do. And what we ask is that you go on a liquid diet for 1 week after the procedure, then progress for a soft diet for the next 3 weeks. And we have lots of diet sheets that explain exactly what that involves, what calories you should be taking, how much protein, water intake, etc., etc. After that, we'd ask that you follow a healthy, calorie-controlled, portion-controlled diet. We also don't want you to stretch any of the sleeve or pouch that we've created. We have excellent dietitian support that's available both at the Sibley site and also at the Bayview campus to help and support you throughout that as well. So in conclusion, endobariatric procedures are minimally invasive, they are safe, and they're effective treatments for obesity. Weight regain after bariatric surgery is common, and endobariatric treatments can reverse a lot of that. We're happy to discuss them with you. We really fundamentally believe that a multidisciplinary approach is key to success and sustained long-term weight loss. Novel therapies are always on the horizon, and we're always looking to incorporate them into our practice and offer them to our patients. This is our website. So it'll give you a lot more information. So if you want anything more about any more detail about any of the procedures, there's some written information on here, some of the videos to give you all of that detail. You're also very welcome to email me or contact us at jhmweightloss@jhmi.edu. And now I'll be very happy to take any questions that you have. If you submit them, like Kristen said, through the Q&A box at the bottom, I'm very happy to discuss them. Thank you very much. So we have some questions coming in, I'm glad to see. So the first question asks, are you able to indicate which procedures are and are not covered by Medicare? And does it depend on the specific patient? So all of the endobariatric, all of the suturing procedures are now covered by Medicare. So we generally can't cover the intragastric balloon, but we can cover the endoscopic sleeve. That's completely covered by Medicare. We can cover the revision endoscopic sleeve. And we have for some time been able to cover the transoral outlet reduction procedure. So, you know, that procedure is also covered as well. So this has really been a landscape change. It's a fairly new development, which happened last year in July. So this, basically, it was a series of events with the merit trial coming out, this excellent data being available, the FDA seeing it and approving the devices specifically for this indication. These devices are the newest iteration of the suturing device we've had around for many years. We now have both of these devices available at Hopkins. So this is Apollo ESG and Apollo Revise. And once we use these devices, we can use this to do these procedures on all Medicare patients, which is excellent. We have another question. So if you have complex medical problems, would this procedure be safe for me? So that's a really excellent question. And, you know, I completely understand where you're coming from. And this is something that many of my patients face. So, you know, when I see a patient in clinic, I go through their medical history in quite some detail. At Hopkins, we very much are used to seeing more complex patients. You know, if you've had obesity for a little while, it's not unusual to have a number of medical problems. And actually getting better weight control will allow you, hopefully, to reverse some of those medical problems. So the first thing we have to do when I see you in clinic is I have to work through what those problems are. It may be that you'll need some additional investigations. That was certainly the case for my patient with liver disease. There were certain things I had to do before we could go ahead with the procedure, just to make sure we did it safely. I may need to talk to some of your medical specialists to see if this is the right thing to do and if they have any input and they agree that it's the right thing to do. And this is, again, is something we do all the time. So yes, if you have complex medical problems, this doesn't preclude you having this procedure at all. So please schedule an appointment. We're happy to discuss that in some detail and talk you through what we need to do to get you to the point where this can be done. We have another question. So are there any age restrictions for an endobariatric procedure? This is a great question. So I think, you know, actually, we don't have any age restrictions. You know, at the lower end, we do offer endobariatric procedures to younger patients. I think the one thing is this is in the context of a few things that I would want to assess to make sure that we're doing the right thing. So in younger patients, I asked them to be seen by one of our heat clinic providers who specializes in adolescent and younger care of obesity. Because I think her expertise alongside this to really see that we're doing the right thing is critical. The other thing is this the right time at that age group? You know, these procedures are often a choice for patients, and you can wait. So, you know, those are important questions to ask, because doing these procedures at the right time also means that you get the most success. So this is definitely something we can talk through, and we have the different members of the group that have particular expertise in assessing patients for this. At the higher end, age is not a limit either. You know, really and truly, it's about you, your health goals, what your medical problems are, and we make an assessment on that basis. And now that we have Medicare coverage, we are seeing lots of older patients that are having these procedures very safely and reversing a lot of comorbidities and having a good lifestyle into older age. Here's another great question. So, is there a BMI limit for ESG? So, an ESG is FDA approved for a BMI of between 30 and 50. And so this is the age group where it's absolutely recommended where we can do this. We do it at patients with a lower BMI who have comorbidities. And we do it sometimes with patients with a BMI of over 50 as well. And this is in certain scenarios. So what I always like to do is ask patients with a BMI of over 50 to see one of my surgical colleagues as well, so they can talk through surgical options, which would be the gold standard at this BMI. But I know some patients are afraid of surgery. It's not safe. They can't have it for various medical reasons. We've also had patients at a very high BMI, whereas it's not safe for them to undergo bariatric surgery at this BMI. And we've done this as a bridge to definitive surgery. So, you know, no, there isn't an upper BMI. We have to see you, we have to assess you, but we can do that. Do you know if EHP covers this procedure? Again, great question. So this scenario, we're learning all the time. So, and it's different throughout the country, and we're having lots and lots of discussions. You know, even probably 12 months ago, insurance coverage for these procedures in this area was almost unheard of. But Merit's really changed that for us. And what we saw was, just before it was published, we were seeing a sprinkling of insurance coverage by the commercial providers. And EHP was one of the groups that started early covering it, and also Blue Cross Blue Shield. But, you know, there's no guarantees here. And there's so many complexities in each case and each provider and each program. So what I would say to you is, you know, some of the best success from what we've seen is when a patient approaches their insurance company and asks them directly, will you cover an endoscopic sleeve gastrectomy? Not a laparoscopic sleeve, an endoscopic sleeve. And often they will be able to tell you directly. And that we found is very valuable information, and often it's borne out into success and having the procedure covered. What we do is we are very happy to put your case together. And what we do is we take all your clinical information and we present that to the insurance company along with all the evidence base for the procedures, and we submit this and wait to hear. So another great question. Do you have any documented diet prior to surgery for any patients, or specifically for Medicare patients? So I think there's two questions in this. So first of all, do we have a diet that we ask our patients to comply to before they come into the procedure, sort of like the bariatric surgeons do for their liver shrinkage diet? We don't. We don't find that it's absolutely necessary that you need to comply to something like that before the procedure. Things we ask you to do that are important before the procedure is, I think it's important to engage with the dietitian, look at your diet, what needs to change, and start thinking about it. These are successful strategies for afterwards. We also ask that you have all your medications available, but we don't set any weight loss goals that you need to achieve before the procedure. Specifically for the Medicare patient, I think what the question might have been getting at is there any specific things I need to do before you approve it? And there isn't for the Medicare patient. You need to meet certain criteria. So you have to have a slightly higher BMI of 35 and a comorbidity, but you don't have to comply to any other diet or lifestyle changes before the procedure. But again, when we see you in clinic, we can go through all of that in detail. What about medications to reduce weight as opposed to surgery? Great question. So look, this landscape is changing all the time. There's more and more medicines that are available. They are becoming better and better for weight loss. Some of them are getting up to very similar amounts of weight loss with medicines compared to endobariatrics, compared to even surgery. But there are problems. In many of these trials, around about 15% of people had to stop because of side effects. Supply is an issue, and we don't know what to do long term. Do you stay on these medicines forever? The way we're thinking about it as a group is that, what you probably need is, combinations of therapy. And in many of our patients, what we do is after these procedures, as we're following you, if you hit weight loss plateaus, we sometimes add in medicines at that point, and that we think is a good combination. We also really like combination therapy for anyone with slightly higher BMI, where you need a bit more weight loss. Bringing together the endoscopic procedures and the medicines in combination, we can get up to almost sort of surgical levels of weight loss without any of the consequences of that. So yeah, it's exciting times for the medicines. Now, if you came to me and you said, look, I just don't want an endoscopic procedure, I want to try some medicines, that's fine. We can get you to be seen by our medical obesity specialist within the HEAP clinic, and they will happily see you and discuss that option alone with you. Another great question. Would a medical condition such as a hernia and the stomach and inflammation rule out being eligible for the balloon? So having a hiatal hernia doesn't rule it out. It's just really a large hiatal hernia. So if it's bigger than 5 centimeters, that's a contraindication, because reflux can get worse after you've had a balloon placed. Inflammation of the stomach, I'd need to know a little bit more information. I'd have to go through your previous endoscopies and confirm what's going on. Most episodes of inflammation are reversible. Often we can treat ulcers or Helicobacter pylori and reverse a lot of that to enable you to be able to undergo a balloon in the future. So not necessarily. Let us go through things in detail. Is the same team available for both Johns Hopkins and Sibley? Is there a preference, differences between the hospital, or is it just location-based? Great question. No, we're all one team. working at both sites. You can consider us as one. So what I do is I work probably 3/4 of my time in Sibley in DC, and I work the other 25% of my time in Baltimore. And we schedule patients at both sites. It's the same scheduling team. It's the same nursing team that will be following you. And our patients are both seen at both sites through the HEAP clinic. There is 2 different dietitian teams, so that would be the only slight difference between the Baltimore side and the DC side. But essentially, same in both places. In some, weight gain is due to hormonal issues, PCOS, hypothyroidism. Is bariatric surgery an option? Again, a great question. So, we absolutely go through your medical history first of all. When I see you in clinic, what I want to really know is everything in your medical history that could be contributing to your weight gain being fully addressed and fully treated. Within the HEAP clinic, there is also endocrinologists, so we can get you a specialty assessment to look at all of those things and make sure there's nothing we need to do to your hypothyroidism to get it better treated that could simply improve your weight by doing that alone. If once we've optimized all of your medical conditions, weight is still a problem, then absolutely, some of these procedures may well be a good option for you. And this is a common scenario we face. And yes, we can totally talk through that. Another great question. Do you find that it's common for insurance to deny the TOR procedure? So this is a very interesting question. So the TOR procedure it's probably one of the very earliest endobariatric procedures. And it's the procedure that we've had the best insurance approval for. There was times where we would have said we'd have got almost 100% approval for it. But one thing I've noticed more recently is that our approvals have gone down a little bit. And I think there's a couple of reasons for that. The insurance companies are probably covering more primary weight loss procedures like the ESG, which has impacted on that. I think also they may have seen some of the figures that, patients come around to needing repeat procedures. And, my argument to this is that, well, we know obesity is a relapsing condition. We know it's a chronic condition, and this may well happen, okay? We also know it's very safe to repeat a TOR procedure. So, insurance approval of late is still far better than anything else we do, but can be a challenge in certain cases. Now, don't be discouraged if this happens to you, because we have a plan B available. And this is to be able to do the first part of the procedure, the heat treatment. So we do an endoscopy with APC, we call it. And this is where we do the heat treatment around the edge of the outlet, which causes a scar and allows it to fibrose down and reduces the outlet in size. Now, what we found is if we do this procedure, this can get the same outcomes as the TOR. The only difference with it is you often need 2 or 3 procedures to get the same effect. But the actual weight loss is very similar between the 2 procedures. So it might just take a little bit longer. So don't be discouraged. We have an alternative should that happen to you. So next question, are procedures done at both Sibley and at Johns Hopkins Bayview or only at Sibley? So primarily procedures are done at Johns Hopkins Hospital in Baltimore, the main site. They're very rarely done in Bayview. And then they are done at the Sibley site in DC. Next question, does Hopkins only assist with revision or further care following weight gain where the ESG procedure was done at Hopkins? Or is there assistance and possibilities if my original surgery was performed elsewhere? Absolutely. Look, we will happily see you after your ESG, even if that's been done elsewhere. You know, really good follow-up is really important. And we recognize that completely. And in fact, I do quite frequently get referrals for just this scenario. Assessment, following long term, and then ultimately, if it comes to you needing revisions, we're also happy to do that in the future as well. What options are available for patients who are a decade post Roux-en-Y and have experienced weight gain? Great question. So for these patients, this is where we really focus what we call the TOR procedure. This is the transoral outlet reduction endoscopy procedure, which is a long term, and we always shorten it down to the TOR procedure. This is a combination of treatments. We use the heat treatment to burn and take the mucosa off the edge of the outlet. This causes a scar, reduces it down in size. We reinforce that with sutures all around the edge of the outlet to really reduce that outlet down to 6 to 8 millimeters or so. And the idea is we get it back to how, your Roux-en-Y was a decade ago. That's the point. We really try and get it back to that point. We're also happy to work on the gastric pouch. That scenario is very, very common, and we can definitely do that. And like I just was talking about to the other patient's question was, what happens if the TOR is not approved? Well, this is where we can also consider an EGD with APC. So great options. We're very happy to talk to you about that. Would previous C-sections prevent an ESG? Absolutely not. So no, they won't. We do talk to you very carefully about your previous abdominal surgeries. And, we want to know exactly what is going on in your abdomen, because the sutures we place are full thickness. They do go through the lining of your stomach. And to do this, we need to be able to pull up your stomach freely to be able to do the procedure. So if you have adhesions or things like that from prior surgery, it's not an absolute contraindication, but we just need to think about it very carefully going into the procedure. Is there an upper BMI limit to endoscopic procedures? No, there's not an upper limit, but an ESG is FDA approved for a BMI of between 30 and 50. The higher BMI groups, we approach carefully, okay? I absolutely want you to have a surgical opinion. It's important you meet with a surgeon and you discuss the gold standard treatment, which is that. It is, this is key to you making clear decisions and well-informed decisions. We may offer you combination therapy, and sometimes with a very high BMI, we use it as a tool to get you to definitive bariatric surgery. But we're very happy to discuss. We've seen this option not infrequently. At a BMI of 50, are the less invasive ways still an option? Absolutely. So this would be outside of the recommended indication for a gastric balloon, but you'd be within the BMI recommendation for an ESG. So that may be a good option for you. Is there a cost for your initial appointment? Well, note your initial appointment and all your follow-up visits and all your appointments with the HEAP clinic will be billed to your insurance. So simply any cash pay options would be for your procedure itself. Last question. What timelines are we looking at for insurance approvals and scheduling, etc.? Great question. And this is something that we really take seriously and are working on ourselves. So what we say is if someone inquires about these procedures, we want to see you quickly. We want to see you within 2 weeks, and that's our aim, okay? Insurance approval can be a challenge. It can take months. The first answer can usually take about 6 weeks, but we are seeing battling going back and forth with insurance companies for 3 months. Our department's happy to do that, but you just have to be patient during that process. So once it's been approved, we can then schedule you, and we schedule you very quickly, and that's our aim. I scope 3 days a week, and we'd hope to schedule you again within a couple of weeks, because we know after all that effort of waiting, you want to get your procedure done, and we completely understand that. We also have access to the medical obesity clinic, and we can get all your other pre-visit appointments scheduled very quickly so that everything is in place for that once we get the green light from the insurance company. I think that's all the questions. Thank you very much, everyone.